Good afternoon, everyone. I am Lynn Sherman. I serve as the Director of Community Engagement at Baptist Health, and I'm also serving as co-chair for the African American Employee Resource Group at Baptist Health. On behalf of Baptist Health and the African American Colorectal Cancer Task Force, thank you. Thank you for joining us this evening for this very important panel discussion entitled, Trust Your Gut and Put Your Fears Behind You. As we work through this panel discussion today, there are a few rules that we would like to go over with you. And those rules have to do with how we'll work together on Zoom. This session, first of all, is being recorded. Our panelists welcomes you to interact with us throughout the session. So as you have questions, click on the Q&A icon that is located at the bottom of your computer screen. In the center, you will also find an icon that says chat. Please click on that icon as well. Please place your questions in the Q&A section. If you want to share your thoughts on the topic, or if you just want to share your experiences with other members of the audience, feel free to use the chat section on the right-hand side of your screen. You can find the button again at the bottom of your screen. We hope that you'll enjoy this panel discussion, and we certainly hope that you will have an opportunity to learn what you might do to prevent colon cancer. I want to share with you today, the subject today is one that is very important to me because my youngest brother, Wilbur, was diagnosed with stage 3 colon cancer at the age of 43. He was the youngest of 10 children. Wilbur was a young man who lived life right. He did all the right things. He was an athletic scholar through high school and through college, was a law school graduate, served as an administrator of a small boarding school right outside of Boston, raising his family, loving life, enjoying life, raising his children. In 2012, he called us to say that he was diagnosed with colon cancer. As I speak of it, I still feel the lump in my chest that I felt on that day. After surgery, 3 years of chemotherapy, he left us. He died at age 36. As you can imagine, this was a huge loss for my family and for this world. It's because of his experience and our experience and the experience of so many other people that I know, I encourage all of you to pay very close attention to what you're going to hear this evening. I encourage all of you to trust your gut and act on it. When colorectal cancer is found at an early stage before it is spread, the survival rate is about 90%, according to the American Cancer Society. Unfortunately, only 40% of colorectal cancers are found at this early stage. This is one of the reasons why we want to encourage everyone to get screened. African Americans are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other groups. And so this evening, we're going to talk a little bit more about why that is so. And we're going to make sure that you understand why it is important that you're screened. And we're also going to make sure that you understand how to navigate this process. This is really important. These statistics are horrible, dreadful, and no one at 90% has to go through it if they simply got screened. I'd like to introduce you to our panelist this evening. Next slide, please. Our first panelist is Dr. Jose Niato. Dr. Niato is a board-certified internal medicine physician, board-certified gastroenterologist, and hepatology. He completed his fellowship in gastroenterology and hepatology at the University of California, Los Angeles, and completed an additional year of advanced endoscopy training in interventional pancreatobiliary endoscopy and endoscopic ultrasound at UCLA Medical Center. I want you to know I practiced that. By way of Orlando, Florida, where he was on the clinical faculty staff at Florida Hospital Cancer Institute, he was essentially in the development of the pancreatic disease and cancer program there. He is a gastroenterologist for Borland Groover, where he practices at Baptist Health in their downtown office. Dr. Nicole Harris is a board-certified family physician and a member of the American Academy of Family Physicians. Dr. Harris is a compassionate physician who understands the importance of listening to her patients. She enjoys the diversity that family medicine offered and the long-term relationships formed along the way. Her areas of expertise include wellness exams, online doctor visits, diabetes prevention care, hyperlipidemia, women's health, thyroid disorders, and high blood pressure. Dr. Landman. Dr. Landman is a colon and rectal surgeon and a world-renowned expert and invited speaker in robotic surgery for colorectal diseases, specializing in the latest minimally invasive techniques for better patient outcomes and sphincter preservation. He is the foremost leader in colorectal surgery for cancer and IBD in North Florida and South Georgia region. He previously served as consultant and specialty counsel, site director for colorectal cancer at Mayo Clinic, Florida from 2008 to 2018. Dr. Landman serves on 2 national committees that oversees accreditation programs and set guidelines and parameters for rectal cancer care in the United States. Ladies and gentlemen, I give to you our panel of experts, Dr. Nicole Harris, Dr. Jose Niato, and Dr. Ron Landman. We will begin our panel by having Dr. Nicole Harris to share with you what is colon cancer, followed by Dr. Niato, who's going to talk to us about how colon cancer is diagnosed. And Dr. Landman will discuss how colon cancer is treated. Dr. Harris?
Hi, everyone. My name is Nicole Harris, and I'm so happy to be with you, and I'm thankful that Ms. Sherman even asked me to talk to you guys tonight. So I wanted to start this talk off with discussing what colorectal cancer is. So the next slide. So basically, it's a form of cancer that affects cells of the colon or the rectum. And if you look at the picture here, I don't know if you guys have heard people refer to the large bowel or large intestine. Basically, when they say those terms, they're referring to the colon. And we have the ascending colon, transverse descending colon, and sigmoid colon. And then you also have the rectum, which is just a passageway that connects the colon to the anus. So when you have cancer that occurs in any of those regions, it'd be considered colorectal cancer. Next slide, please. So what are the symptoms that you should be looking out for? Well, one of the symptoms is a change in bowel habits, and that's constipation or diarrhea. You know, a lot of patients will think constipation or diarrhea is insignificant, However, if you're someone who's been having normal bowel movements for some time and then you have new onset of diarrhea or constipation, it's definitely something you should bring to the attention of your primary care provider. Another common symptom is blood in the stool. Patients will sometimes complain of stomach pain or gas pain, which they may even describe as cramping. Even with the bowel movements, patients' bowel movements may be normal, but they may say, I'm having a bowel movement, but it doesn't feel like I completely empty when I have a bowel movement. So that's significant. Another thing you should be on a lookout for is unexplained weight loss. I mean, all of us are trying to be a certain weight nowadays. However, if you know that there's not been a change in your diet and you're not exercising regularly and you're just dropping the pounds, it's definitely something you need to see the doctor about. Not saying it's colon cancer, but something needs to be done to figure out why it's happening in the first place. Also, patients may complain of chronic fatigue or weakness as well. We can go to the next slide. So, what causes colorectal cancer? Well, you guys, really, in all my reading, there's not an exact cause of colorectal cancer, so I can't say this exactly causes it. But what we do know in the medical field that there are risk factors associated with the disease. So when someone says risk factor, they're just saying anything that increases your chances of getting a disease, such as cancer, and in this case, colorectal cancer. We can go to the next slide. So when we talk about the risk factors, first, age can be a risk factor. As we increase in age, it increases our risk. It is more common in patients who are 50 and above, but it can occur at a younger age. So that shouldn't deter you from expressing your concerns to your primary care provider. Another common cause or risk factor, I should say, is inflammatory bowel disease. And that's diseases such as Crohn's disease or ulcerative colitis. So if you or family members have a history or known diagnosis of this, a lot of times you're already under the care of a gastroenterologist who is following this, but it's definitely something that should be monitored. Also, family history of colorectal polyps or colorectal cancer is a risk factor. And I put everything on two different sides because I really wanted to specify, age. You can't control that you're aging. You can't control if you get inflammatory bowel disease. You can't control if you have a family history of colorectal cancer. You can't even control your racial or ethnic background. But the other risk factors that I'm going to discuss, you do have control over. And that would be being overweight or obese. So if your body mass index, which is determined by your height and your weight, falls in the overweight or obese category, this would be a reason for you to want to get on a weight reduction program to decrease your risk. Also, physical inactivity is a risk factor as well. So it probably goes along with being overweight and obese because typically patients who are obese or overweight don't have a regular exercise regimen. Also, diet is important, particularly high fat diets and diets rich in red meats put you at risk. So that's something to consider. Diabetes or insulin resistance is a risk factor as well. Smoking puts you at increased risk for cancer, and really smoking puts you at risk for pretty much every cancer out there, but it is associated with colorectal cancer as well as moderate to heavy alcohol use. And to get a definition of that, I'd say for male patients, greater than 2 drinks a day, and for female patients, it would be greater than 1 drink a day. We can go to the next slide. So why are African Americans at greater risk? So in the US, we as African Americans have the highest colorectal cancer rates of all ethnic groups. And as Lynn stated, our mortality is 20% higher. Because of this, the American College of Gastroenterology recommends screening begin at age 45. And even in my reading on this, there was no clear reason stated on why this occurs, but I do have my own theories. One is healthcare disparities. I mean, it's a known fact that in a lot of African American communities, access to care is limited. And because of that, a lot of patients don't get their routine physical exams and routine screenings that they should get. Also, access to insurance and things like that can interfere with their ability to get their routine health maintenance. Another thing I think plays a role in the African American community is perceptions on what to expect on getting a colonoscopy, or even fear about getting it in the first place. And Dr. Nieto is going to talk more about what to expect when you get the procedure from his own experience. But I always tell my patients, it's important to remember not to let fear drive your decisions. If you're having any symptoms, I don't care if it's nausea, constipation, diarrhea, no matter how small it is, if you have health insurance, there's no reason for you not to go in and express your concerns to a physician. Because if it's nothing, when the workup's done, it'll show nothing. But how beneficial it would be for you if we detect a colorectal cancer in time, and that prevents you from mortality in the future. Thanks.
Thank you, Dr. Harris. Now we'll have Dr. Nieto to come and share with us what it's like and what does it actually take to diagnose colorectal cancer. But I want to remind our audience that if you have any questions, please feel free to place them in the question and answer box. These physicians are here and ready and prepared to answer any questions that you might have. All questions are good questions, and so feel free to ask your questions. Also, remember, if you want to share any stories as it relates to colorectal cancer concerning yourself or your family, please put that in the chat. We want to hear about it. Thank you. Dr. Nieto.
Ms. Sherman, thank you so much for this very nice introduction, and welcome to everyone who is listening in today. This is extremely important, this topic, and not just to African Americans, but to everyone in general as well. One of the most important things that I learned is being a patient, not just a physician. Last year was my first year of having a colonoscopy, and I'll talk to you throughout the experience. Yes, as a physician I've done thousands of colonoscopies. I was scared during the procedure, obviously before the procedure, but I think it's just a natural reaction. And I'm here just to tell you about my experience and to tell you how easy it was to undergo a colonoscopy, and also to discuss, how do we diagnose and screen for colorectal cancer? Okay, trying to change, there we go. So this is extremely important. What are the symptoms of colorectal cancer? I get asked this every day. I'm not bleeding. They tell me, well, doctor, I'm not bleeding. I don't need a colonoscopy. I don't have a family history. I think I'm okay. Well, the most common symptom of colorectal cancer is actually not even having any symptoms. And that's why it's so important that we undergo a screening test to detect it early before it actually becomes cancer, or when it's really early, and we can actually get cured, or at least have a very high rate of cure, which is about 90%. And other common alarming symptoms that Dr. Harris also touched upon are rectal bleeding, rectal pain, weight loss is unexpected, anemia, or your changes in your bowel habits. And what that basically means is you're having your routine is maybe you have a bowel movement every day. Well, now you're having one every 4 or 5 days. That's a significant change. But again, these are alarming symptoms, because when these symptoms start occurring, you may be in a situation where you're now at stage 3 or 4. You want to try to catch these cancers when they're just polyps, when they're just abnormal tissue that have not even transformed into cancer. And that's why screening is so important. And then we divide up colorectal cancer screening in basically two, high risk and average risk. Average risk is basically anyone who doesn't have any signs or symptoms or asymptomatic and zero symptoms, like I was last year. And increased risk is when you have a family member, a brother or sister or parent that has had colorectal cancer, including second degree relatives as well. And then high risk are now there are groups that, they have inflammatory bowel disease, either Crohn's disease or ulcerative colitis, or you have a family history of genetic syndromes for colorectal cancer. But the majority of our patients fall into the average risk category. So what's colorectal cancer screening? Well, there's two types. There's either stool tests or visualization tests. Well, the first common ones that we used to use in the past, the first ones that were out were what's called the highly sensitive FOB test, or fecal occult blood test. That means it's just checking if they happen to find blood in your stool. And that could, as you can see, you can have a positive test if you take it maybe a daily, like a daily aspirin or something that can cause you to have a little bleeding. You may have internal hemorrhoids that can make that test falsely positive. And if anyone, that's not the standard of care, but it's better than doing nothing. A FIT test is just a little more specialized, fecal blood test. It's called a fecal immunohistochemical test. And that's also done yearly. And then we have the newest one, which is a FIT DNA test, which includes the FIT test with these new genetic markers that are looking for genetic abnormalities in your stool that can suggest either colorectal cancer or abnormal polyps, as we see here to the left. And then the standard of care, which is colonoscopy. Colonoscopy is a camera that goes and looks throughout your whole colon. And not only does it screen for colon cancer, it means it finds polyps or cancers, but if it finds polyps, it's able to remove these polyps, as you can see here in the picture between A and B. And by removing the polyp, it prevents the growth of that polyp to ever become cancer. So not only is it a screening test, but it's also a therapeutic or preventative test as well. And CT colonography is basically a CAT scan to look at your colon. But again, those tests, as you'll see in the next slide, they're not as accurate. So as we can see here, green is basically a colonoscopy, which is our gold standard for making the diagnosis of colon cancer and also finding polyps, compared to Cologuard, which is in like an aqua color, and then a light blue color looking just at FIT tests. So you can see finding colorectal cancer, they're all pretty good, obviously colonoscopy being the best. But when we start looking at these other more aggressive polyps with high-grade dysplasia, means they're just about a year away from colorectal cancer. It's, again, 97%, much more sensitive. This drops down to about 70%. So it means 30% of the patients, by either doing a Cologuard or a FIT test, is going to miss out on those types of polyps, over 50% here. And then when we're just looking at just tiny little polyps that may or may not ever turn into cancer, it significantly drops. So this is just kind of giving you an overview of the different tests and how good they are in detecting cancer or detecting polyps. So why is colorectal cancer why is this topic so important to African Americans? In 2016, the American College of Gastroenterology appointed me as the chair of the Diversity and Cultural Committee, and I was appointed for 3 years. In those 3 years, one of my biggest tasks was to look, where there was need, and one of the biggest needs we found is are we properly screening African American patients for colon cancer, since we've seen such a high rise and the disparity of how their outcomes are. So when we actually did, we actually were the ones who wrote up the guidelines. We found that there were significant health disparities. There was also genetically, there were some more aggressive cancers that present African Americans, even at an earlier stage. That's why we came up with the recommendations at the age of 45. So as Dr. Harris explained very beautifully, all the different reasons and all the different health disparities that do exist. And that's exactly what we found. But there's also a genetic component as well that puts African Americans at higher risk of not just having cancer, but more aggressive cancer. And what I mean by that is they'll get to stage 3 and 4 much quicker, as opposed to some of the other ethnicities. As we can see here, it's diagnosed with colorectal cancer at a younger age. It's very common in African Americans. African American colorectal cancers do have a decreased survival compared with other ethnic and racial groups. And again, this is because of the more aggressive cancer. This is why this is so important. So the next step that I want to go over is what was my patient experience? This is what the way I wrote this is the way I experienced it, but also as a physician, what happens. So the first part is you meet your physician, your primary care physician. Like Dr. Harris will refer you to one of the gastroenterologists for your screening test. You meet your physician, actually in this case for a colonoscopy. You meet your physician. You go over all the your past medical history, if you have diabetes or if you don't have diabetes, what to do with your medications, what to stop, what to continue. There are dietary recommendations we give prior to the colonoscopy, such as stay away from lettuces as they can stick to your colon. So we want your colon to be really clean. And then we go over the colon cleaning prep, and we'll give you specific instructions when to start on a regular clear diet, liquid diet, and how to progress to a regular diet after the procedure. The day of the colonoscopy is, we're all anxious. I was anxious, a little anxious and scared, but most important thing is stay calm. Everything will be fine. Your doctor will take great care of you. You're not to have anything by mouth that morning. You can have a small sip if you have specific medications you need to take, such as your blood pressure medications. Most cases, anesthesia is used, and it's not general anesthesia. It's more like a deep conscious sedation or a deep sedation with a medication called propofol, or sometimes with Versed and fentanyl. Depends where center is doing it. The procedure can take anywhere between 20 to 60 minutes, depending on how many polyps you have, or if your colon is very long. For different reasons, this can happen. Once you get into the room, the nurse and the physician will talk to you, identify who you are. We'll make sure you're there for the right procedure. And next, you'll count to about 10, and you'll be asleep, and you'll wake up and in recovery. And hopefully that time your physician will go over your results with you, and you'll have a follow-up for your pathology if they found any polyps at that time. So depending on how many polyps they find, the guidelines determine when you're next to have your next colonoscopy. So one of the questions I always get asked, what are polyps? Where do they come from? There's actually benign polyps. As you can see here, these are what's called hyperplastic polyps. They're completely benign. They will never turn into cancer. And so we have some inflammatory polyps, which we usually see in patients who have inflammatory bowel disease. And then we have polyps like this. This is just what's called a submucosal lipoma. It's just a little bit of fat in your colon. These are completely benign. They're not cancerous. These will never turn into cancer. Then we have other types of polyps, which are genetic syndromes. As you can see here, they have multiple different types of polyps, and they tend sometimes to fill the whole colon with polyps. And then some of the other polyps that we normally see is these, what's called the flat polyp, the serrated adenomas. They look very, very similar to the surrounding mucosa. As you can see here, they're very flat, and they're actually very difficult to find sometimes. These could be very aggressive. And you have these larger polyps. As you can see here, these polyps, this is how the progression of a polyp into colon cancer is developing, as you can see here. This is actually what we see when we do a colonoscopy. And then I'm going to walk you through a video of what we do when we find these polyps. Well, sometimes the polyps are really big, and we have Dr. Landman to help us remove them with surgery. Sometimes they're not too big, and we can do a special procedure called a polypectomy, or in this case, an endoscopic mucosal resection. So what we're basically doing is, here's a big polyp. We're going to inject it with a special solution, and the solution is going to put a big, what's called bleb, or kind of a cushion underneath it. And then we're going to use this little device right here called the snare. It's kind of like a little loop. We're going to loop around it. As you can see here, we're going to loop around it. We're still injecting there. As you can see, here's the cushion right below. We have a loop that's gone around, and we're going to just kind of shave this off your colon. And by doing this, not only are we diagnosing an abnormal polyp that will turn into cancer very soon, but also actually removing it and preventing from this polyp ever causing colon cancer in your body. And at the end, as you can see here, the snare removing it. Sorry, the video is going a little slow. As you can see here, it starts looking really snug as we put this around there, and we slowly use a little, what's called cautery, little coagulation cautery, and we cut right over it and just kind of slowly shave it off. So you can see it'll come off in a second. There it is. Part of it is removed, and we'll remove this part. And that's what it looks like after. This is just the base. This is just what's called the submucosa. What we end up doing next is we will put little clips on there and close up the little defect. So what is the conclusion? You know, the most common symptom of colorectal cancer is not having a symptom. I think that's why screening is so important. The majority of patients do not have any symptoms. Stool tests and colonoscopies are the most common screening tests that we see for average risk patients. So for example, the Cologuard test, the FIT test, colonoscopy tests are the most common tests. Colonoscopy is the gold standard for screening and prevention of colon cancer. So you can see we're not just screening, but at the same time, we're actually preventing colon cancer by removing these polyps. And the American College of Gastroenterology, which I was part of this specific committee, we recommend that African Americans start screening for colorectal cancer at the age of 45. We also recommend shorter intervals of when they have their second follow-up colonoscopy. So thank you for your time. And you know, as a physician and as a patient, having a colonoscopy was a very good experience. It was did not feel anything after I woke up, and yes, I was nervous, like I think anybody else would be, but it was the right thing to do. I have a family of 2 kids. I want to be here as long as I can for them, so I can spend as much time as I can with them. So a lot of times we do things not just for ourselves, but also for the people around us that love us. So I think that's extremely important that we take that into consideration as well. Thank you.
Thank you, Dr. Nieto. We really appreciate you sharing with us how colon cancer is diagnosed. And so once we understand what it is and colon cancer then gets diagnosed, there has to be treatment that follows it if it is diagnosed. And so this evening, I would like to just introduce you all again to Dr. Ron Landman, who will share information with us on how is it treated once you are positively diagnosed for it. Please remember to continue to put your questions in the chat and in the Q&A box as well. And I love the way you all are sharing your experience with colon cancer in the chat. Continue to do that, continue to talk to each other, because that's how we learn, by getting information. Dr. Landman?
Thank you very much, Ms. Sherman, and thank you again to my other colleagues and co-hosts. I think all of us are really pleased and really happy to be doing this for a community as an outreach effort and educational effort. If I could go to the next slide. The next slide is fine. All right, so I'll talk briefly about what a brief synopsis of what my talk is going to be. If you listen to nothing else, listen to this one slide. Basically, colonoscopy is critical for all patients. There's a lot of tests that you can get. That Dr. Nieto described so eloquently. But the only test that actually works is the one you actually get. So whatever you choose, I think we all have a preference because it's actually both diagnostic and therapeutic for colonoscopy, but please just get it. It will actually save your life. Hopefully that way you'll never need to remember anything I say for the next 5 to 10 minutes and never have to take advantage of anything I can offer. But if you're diagnosed with colorectal cancer, medical and surgical care now for colorectal cancer, CRC, is now much better and less invasive than it ever was even just 2 years ago. And again, once again, get your colonoscopy and avoid me. Next slide. So what happens now that you got your colonoscopy or you got your Cologuard? that suggests there is positive, and you get a colonoscopy that demonstrates a cancer, the big C. The first thing you need to remember that this is not a death sentence by any means. But when you do get diagnosed with colorectal cancer, at that point, your first reaction and the first thing you really need to do is to really seek expert surgical care at a multidisciplinary cancer-focused center, such as the one that we provide all our Baptist patients at Baptist MD Anderson. We offer surgery that is now a lot less invasive than it ever was, a lot better with much better results. And in combination with a multidisciplinary approach using both medicine, radiation, and surgery, we can minimize those interventions and significantly improve your survival and your ability to be out there with friends, go to your children's graduations, go to weddings, go to vacations, and all the important milestones that everyone deserves to experience. Next slide. So the operations for colorectal cancer. We know that no one wants one. We only reserve them when no other endoscopic techniques or any other less invasive modalities are available. Frankly, that's the benefit of a colonoscopy, because even if you do get a large polyp that's very early stage, you could have someone like, there's not that many of them. There's actually very few of them nationwide, but we're fortunate to have Dr. Nieto, for example, this case, and his son, available to, remove these polyps endoscopically and again, get a cure that way and avoid me. The care for, patients with colorectal cancer is personalized, it's individualized, but it is very complex, with our goal being not just cure, but an improved quality of life for our patients and also their families. We can't lose track that we're not just treating the patient, but we're treating the family as well. That's vitally important. Next slide, please. So again, surgery is just a single part of a multidisciplinary approach to the management of colon and rectal cancer. We collaborate with our colleagues in GI, medical, and radiation oncology, and it's just one of many tools that we have in our toolbox. And again, treatment is individualized. It's based on your disease and location and staging. And again, with an overall focus on cure, survival, outcomes, but also quality of life as well. Next slide, please. But how about picking your surgeon? Unfortunately, there have been a couple of studies that have shown that most patients spend more time doing research looking for a car and will go to 2 or 3 dealerships, yet don't spend any time going online to choose their physicians or surgeons. But we do know that if you seek care by a highly trained, high volume surgeon in that particular operation, not just any operation, but one particular operation, patients are then more amenable and more likely to get a multidisciplinary approach, a higher rate of minimally invasive surgery, improved short and long-term outcomes, a higher sphincter preservation rate, which means you're less likely to have a permanent bag or colostomy. It's actually cheaper, and you have better cancer outcomes. In this case, when seeking a surgeon, specialization matters, but subspecialization, such as colon and rectal surgeon, who also is focused on cancer, matters even more. And you only have one body, and you really have one good chance at this, so you want to make it count. Next slide, please. These are some of the surgical treatments that we have that have been evolved and improved just over the last couple of years that we really weren't doing until then. We do these advanced procedures, for example, complete mesocolic excisions, even for standard basic colon cancers. And I think there's probably about maybe 20 to 50 surgeons who do this routinely in the country. I do this routinely. It improves the ability to remove more of the lymph nodes associated with a cancer, which improves survival, which also improves the likelihood of the cancer not coming back again. When we're dealing with rectal cancer, you have a reduced risk of the cancer coming back in the pelvis and also improved overall survival. And you're also more likely to get someone who specializes in robotic surgery, which improves the quality of the dissection, and also importantly for the patient, for both, from a GI standpoint, the ability to go to the bathroom, while sitting on a toilet, but also to improve sexual and urinary function, and also body morphology and how you look at yourself in the mirror and in front of your loved ones. Next slide, please. So how do we do these operations? These are pretty advanced, complex operations. Traditionally, when I was trained, we did these all through an open traditional operation with a big incision down the middle of the belly. Then, in fellowship, we learned laparoscopic surgery, but we still had a pretty sizable incision, about 3 inches, about 5 inches or so. And now we've pioneered robotic surgery, particularly here at Baptist, which is basically, you can think of it as computer-assisted or computer-aided laparoscopic surgery. You see the robot there. And what this does is, for the patient, it's significant in that it reduces pain. You have a shorter hospital stay, a quicker return to home and work, and it's overall a better operation. Next slide. Because these have been the traditional standards for patients with, for example, for rectal cancer, one of the most challenging and most difficult colorectal cancers to treat. When you do an LAR, you can hook patients back up and they don't need a permanent bag. But if traditionally, many patients required what's called an APR, where you remove the entire rectum and anus and leave them with a permanent bag, which is not ideal for patients. And we want to shift the curve to the left, so more patients are able to get a low anterior resection, an LAR, to avoid a permanent bag. Next slide. So this is a traditional operation. I don't know if for some reason the line isn't going through. Next slide. The laparoscopic, one of the lines didn't show up, but you can see, laparoscopy uses very small incisions about the width of your index fingernail, but you still have a pretty sizable incision, about, like I said, 3 to 5 inches. And then next slide. With robotics, we minimize that to even smaller, to about literally 1 to 2 inches, if that. But what if you've had prior open operations? Well, prior laparotomies are no longer contraindications. This is a patient who had an accident in the 80s, I believe, and had an incision that I marked with a marker all the way up and down his abdomen. But you can see the 3 little incisions that I put on the patient's abdomen. We did the entire operation through those 3 little incisions that are literally the width of your fingernail. And at Baptist MD Anderson, I'd like to say, and I'm very proud in saying, that robotics is the gold standard and a standard approach for all our patients. And you should probably request a board certified colon and rectal surgeon who has particular expertise in cancer surgery. This will get you higher volumes and better outcomes. Next slide, please. Again, we're very fortunate that we have the highest volume of low anterior resection in the county, with a lowest complication rate, a shorter length of stay, less pain, quicker return to work and school. We have improved bowel frequency and improved quality of life when doing robotic surgery that we offer to our patients, all our patients at Baptist MD Anderson. Next slide. And again, if you're diagnosed with a colorectal cancer by any gastroenterologist, by coming to BMDA, we can tailor and individualize and personalize your treatment to your particular situation. And I'll be the first, if I see something that I think, another gastroenterologist said, oh, it's not possible to remove endoscopically, needs an operation. I've referred these patients to, our advanced GI group with Dr. Nieto, and we've been able to remove these lesions with another advanced colonoscopy like he demonstrated and avoid an operation. Even though I'm a surgeon, I'm happier when I'm able to offer a patient a non-surgical approach. Otherwise, we do offer surgical, robotic, and transanal approach in combination in certain cases with both medical, such as chemotherapy, and radiation oncology. And in some instances, particularly with rectal cancer, by using both medical and radiation oncology, we can actually avoid an operation completely and get complete cure that way as well, which is something that we brought to BMDA, and we're probably the first to practice here in the Northeast Florida, South Georgia region. So we're very happy about offering that to our patients. Next slide, please. Again, we have the highest rate of sphincter preservation in Northeast Florida, with the highest rate of minimally invasive surgery, with all the improved benefits that we discussed, including the ability to almost use no narcotics or opioids. And we like to tailor our approach to each individual patient, not just one size fits all, because each one of us is individual, and we deserve, and all of you deserve, to be treated appropriately and personally. Next slide, please. How to prepare for surgery. This is really important, and I think Dr. Harris sort of mentioned this later on. But if you do get diagnosed, with colorectal cancer, now is not the time to, avoid sugars, avoid this, and do all these fad diets. What I would do is focus on a lean protein intake, really improve your nutrition with fish, chicken, eggs. Try to target an ideal or normal body weight. If you are overweight and your body mass index is greater than 30, go to your primary care physician. There are special weight loss shakes that are physician monitored. And in some cases, some patients may require bariatric surgery to get patients to an ideal healthy weight, because what we found is that patients over a certain body weight, the operation is less than ideal, and in some cases prevents patients from having a safe operation or the appropriate operation where we can connect them together and avoid a permanent bag. If you do have diabetes, you really have to maintain your blood sugar control and your diabetes and target your hemoglobin A1C to less than or equal 6.5%, because otherwise you're at a significantly increased risk of complications, which we do not want. Next slide, please. Again, it's a multidisciplinary approach. Seek expert medical and surgical teams. Treatment for cancer is almost always curative. Your first shot is the best shot. You really want to pick a surgeon who has high volumes and subspecialization in colon and rectal cancer with techniques and skills and robotic surgery. And again, our primary goal is cure and improvement in the patient's quality of life. Next slide. And indeed, in that effort, we are hopefully soon to be the first ones in the region to be a nationally accredited rectal cancer program. We are awaiting formal, we had our site visit. We just need to go through some final audits, and we seek to get that soon and hopefully be the first in the Northeast and South Georgia area. And so we're really pleased to be able to offer that to all of our patients in our community. Next slide, please. All right, so going back to my first slide, conclusion, just get screened. No matter what you do, please get screened. If you do get diagnosed, seek a surgeon with high volumes, specialty expertise. We offer a multidisciplinary approach, sometimes even non-surgical, with the goal being improved survival, improved on cancer outcomes, avoidance of a permanent bag, and improved quality of life. And again, we're here for you at Baptist MD Anderson Cancer Center. Thank you. Next slide. I think that's all I have. Ms. Sherman, back to you.
Hi, Dr. Landman. That was quite an interesting slide, the last one, when we got to the very end. But thank you for sharing that with us. We have quite a few questions that's come from our audience, and I think we're going to begin with those questions and for our panelists. And we want to really thank our audience for being so good about asking these questions, because we do believe that the way we're going to educate the community about the need to be screened and to diagnose colorectal cancer early, if you have it, is by doing educational opportunities like this, and simply just talking and not being shy about sharing with one another. So we do have a question first here from Damon Green. Has there been an AMA recommendation that African Americans get colonoscopies earlier than age 50?
If you don't mind, I'll be more than happy to answer.
Dr. Nato? Mm-hmm.
So the answer is no, there isn't. The only recommendation, to my knowledge, is from the American College of Gastroenterology, or the ACG. Up to today, there's nothing specific for African Americans other than that recommendation that we currently have. And I'm going to be honest with you, it was very difficult, even for us, after having significant amount of data and research that we put together for several years, over 3 years, and accumulating research from previous papers. It was even difficult to actually get that at 45. And there are still some societies that feel that 45, it shouldn't be 45, it should actually be 50. So there is still some more debate on that. But right now, it's only the American College of Gastroenterology that's recommending that. Now, the Cancer Task Force is recommending that everybody get screened at 45, which is based on the newest guidelines that have been presented.
Okay, so Dr. Nieto, I have a similar question here too, along those same lines, if you don't mind responding to it. As we learn more about African-American males dying in their 40s from colon cancer, do you anticipate the ACG guidelines being revised to address changing the current screening age from 45 to perhaps 35 or 40?
So we've talked about, these discussions have been going on for the last 5 or 10 years, and initially what we had recommended was 40. So I think as more data comes out and we're able to we actually have more African American patients getting screened, and actually some presented with colon cancer earlier, or being picked up at the age of 40 much earlier, and then we have their family members getting screened sooner. I think we'll be able to have significant amount of data that will allow us to show how important it is to actually decrease that age. Well, whether it's 35 or 40, we don't know the answer to that because we don't have that data yet. Just because we have very few people being screened at that age, so we don't have that information. But it's a great point. We don't know the answer yet.
Thank you for that answer. Tammy McGriff asked, or she says that she's 50. She did the Cologuard test and it was negative. No, there were no significant risk factors. Should she consider a colonoscopy? And Dr. Nieto, you want to take that
Sure.
one as well?
I didn't want to answer all the questions, but I think it is appropriate for me. The answer is she's at average risk, has had a Cologuard test with a very good sensitivity. The recommendations at this point is for her to either consider Cologuard again or colonoscopy at 3 years.
Okay.
That's based on the guidelines. Okay. Now, that being said, if she develops rectal bleeding, has a family, all of a sudden has a brother or sister that develops colon cancer, or has significant amount of polyps, and she finds this out, let's say a year and a half from now, then she should definitely consider a colonoscopy.
Okay. Thank you very much. So several of the questions are diagnostic. And so if you would answer this one again, Cologuard has an alternative use when the community lacks resources for colonoscopy. many times because they live in a rural area or are uninsured. But what if they cannot get a follow-up colonoscopy after testing positive on a Cologuard test? Isn't that a good example of health disparity? So you can answer that. I'd like to hear from each of you on that question, if you don't mind.
So, I mean, that's a great question. I mean, Cologuard is, it is an alternative. And one of the most important things about Cologuard, if you're in a small town where you don't have access to care, or you just don't feel comfortable undergoing a colonoscopy. But there is, some of these small towns do have an issue with providing that colonoscopy for that positive Cologuard test. So it has to be a system in place. If you're going to offer a Cologuard, you have to be able to, that percentage of patients who have a positive Cologuard need to already be, set up in a system where they do have that colonoscopy done. Because if the Cologuard is positive, you still need the gold standard, which is a colonoscopy. And this is a point that's extremely important. If you have access to Cologuard, you should basically plan to have a colonoscopy done unless that test is negative.
Dr. Harris, would you like to respond to that as well?
Sure. Well, what I wanted to say was piggybacking on what Dr. Nieto said. Definitely, if a provider is ordering a Cologuard, because it's a physician ordering, there needs to be a plan in place on how to treat those patients if it comes back positive. But particularly, I wanted to mention in Duval County, as far as uninsured patients are concerned, there are options available. UF Shands has the city contract program for patients who don't have insurance and don't have the money to pay for insurance, that they can qualify for and get their routine screenings, such as mammograms and colonoscopies. That's one avenue they can take to get a colonoscopy or even the Cologuard. But at least in that situation, if the Cologuard's positive, they would then be able to get a colonoscopy. And even with the working uninsured here in Duval County, there is a clinic called Volunteers in Medicine, and they actually have gastroenterologists in our community who volunteer. And so if you meet the screening guidelines, you're able to get your colonoscopy through that program. And what you pay is basically on a sliding fee. But for that clinic, you have to be working. So you have to be working and not have insurance, and you can qualify through that avenue. So that may be helpful if you know someone who's uninsured who may be battling that situation right now.
Thank you, Dr. Harris. And while I have you, I want to ask you the next question that has come up. What if a person does not have a family history for colorectal cancer, but felt very strongly about having a colonoscopy because they just don't feel right?
Okay.
Will it be covered by insurance?
Yeah, well, that's a tricky one. Now, if they're falling under the current guidelines, like they're having signs and symptoms that put them at risk. So you may not have a family history, but if you're having change in stools or blood in your stool or cramping, those in and of themselves can qualify you to get a colonoscopy. So it wouldn't be so much screening, it'd be more diagnostic based off your symptoms that you're having, I would assume. So that would be an avenue to get it. So I wouldn't if they're not going to cover your screening at 35, but you're having bloody diarrhea or chronic constipation or cramping and bloating, I would still refer you to gastroenterology to potentially get you a colonoscopy if your symptoms warrant. But whether your insurance will cover it is really dependent.
Okay. Thank you for that. Dr. Landman, are there promising clinical trials for new therapies that are coming about?
Yeah, well, I think we're working on a whole host of new trials that we're participating in. Some of them are for surveillance. We are currently running a trial in a select group of patients who have stage 2 or 3 disease, and using the tumor's particular DNA, again, individualized, personalized to that patient and that patient's cancer, individual cancer, to follow them and do surveillance for that. In terms of treatment, there are new advances in more of the advanced stage colorectal cancers and the stage 3 or 4 disease. There are some newer biologics and immunological therapy that's being investigated and utilized routinely in certain types of hereditary type colorectal cancers, which really only found in 20 to 25% of patients. But yeah, we are investigating new channels of both diagnosis, treatment, and surveillance. And we try to make any patient that we see at Baptist and Baptist MD Anderson available to those trials and studies.
Thank you, Dr. Landman. I have another question that you may be able to answer for us. Is immunotherapy an option for most people or only particular people?
It's really an option for a select group of patients, and also based on the stage. Again, we test those patients' individual cancers for particular changes in the protein expression or the profile of each individual tumor. And based on those assays and those tests, we can determine whether a patient and their cancer would be responsive to these newer immunosuppressive therapy or biological therapy that are out there, including many people have heard of Keytruda. It's all over the news and all over the TV, Keytruda, but other medications like cetuximab and other medications as well. So unfortunately, though, it's actually currently unfortunately and fortunately, it's a small amount of patients that would benefit, but it's also a small amount of patients that actually need it. The current line of chemotherapy agents that we have, and not that many people actually need it. Most patients do not need any additional chemotherapy or radiation, okay? Most patients either need an advanced endoscopy if they're diagnosed with cancer. They need an advanced endoscopy or just surgery. But if they do need it, it's usually a standard line chemotherapy, and in some cases, radiation therapy. So yeah. Okay. But even that we've modified to improve, to shorten the duration, and in some cases it actually removes the need for surgery too, which is, great for the patient. So, yeah.
Thank you. Thank you for that answer. So there are several questions about PrEP and that the audience has. Why is it important? Why is it so important that people do the PrEP appropriately? And has there been any changes over the years in simplifying PrEP? And I think, is that question for Dr. Nieto? Since I think you're the one going in after the PrEP.
Well, actually, Dr. Landman and myself are both appropriate to answer the question, but I'll give you my version of it as well. Has the PrEP evolved in the last 10 years? Actually, I've been a gastroenterologist now for 17 years. It's been a long time, but and it hasn't really evolved very much. We've gone more from, more volume to less volume. So from instead of 4 liters to 2 liters, and there's some PrEPs now that are pills. They're just a lot of pills. I remember about 10 years ago hearing about Hershey having a formula of a brownie. You can eat these brownies, that will be your prep. I'm still waiting for them to develop that. That would be a great prep. But as of now, the prep is about the same. The things that we've done differently about the prep now is we've gone now more to split prep, where if it's a 2-liter prep, you're going to take your first liter one day and then split it and take the second liter a little bit later or the morning of the procedure, at least 4 hours before the procedure. And what we found is that actually gives you a better prep for us to make that diagnosis. And one of the other things that I ask my patients to do is I tell them to stay away from everything with fiber. So in other words, all the green leafy vegetables for a few days, at least 5 days prior to your colonoscopy, because they tend to stick to the walls of your colon. Same things like corn, things like that. None of that. If they're onions, if you get rid of most of that, the prep actually isn't as rough. It's a lot easier to have your prep. At least that's what my patients have told me, based on them having a previous colonoscopy. This is their second prep they've done. The prep that I use, it's the most common prep. It works very well. And it's not, doesn't mean it's the right prep, just the one that it's a lot easier for me to use. It's basically Miralax prep. It's basically the whole bottle of Miralax in 2 liters or it's like 64 ounces of prep. So it isn't that bad. That's a prep that I did. It wasn't bad at all. Yeah, it is. I wish there was something easier. But those are the key points regarding what the preps are like. And are preps extremely important? The answer is yes. The better prep you have, the better exam we have, and the safer it is if I find one of these big polyps for me to safely remove it, because it just makes everything so much easier. And your colonoscopy is actually done, and with a better prep, we take less time to do the colonoscopy because we don't have to constantly clean out the area and wash out the area of that area of the colon. So you get not only a better diagnostic yield, and that's also been proven, you get a much better diagnostic yield. You get a colonoscopy doesn't last as long, so you're under anesthesia for a little bit less. So I'm just curious for Ron's his opinion, his advice, his extra advice on this.
So it looks like I have a lot more white and gray hair than everybody else on the panel. So I have some experience with this as well. So when we first started, and frankly, it's still an acceptable standard, everybody got this giant jug, basically 4 liters or a gallon of this kind of salty powder, and they mixed in with water, and you drank that. Frankly, it's still an acceptable standard in a certain number of patients. However, we have gone to as well. I currently also, even for operations, I also use the Miralax prep because it's safe, it's efficient, and patients just tolerate it a lot better by just buying some over-the-counter Miralax, over-the-counter Gatorade, whatever flavor they want. Try to avoid the red one, red-colored flavor. But it's generally well tolerated. And in the case of when we do operations on patients, we sometimes will give them some anti-nausea pills as well. But most patients tolerate this a lot better than they did in the past. And some gastroenterologists do like to prescribe, and they're actually a lot more effective, these split preps as well, where, like Dr. Nieto said, you do some at night and some several hours before you go in. But again, the key to the prep is you can't diagnose and you can't treat. For example, in Dr. Nieto or any gastroenterologist case, something that you can't see. So if you don't have a good prep, you can't see everything. You really need to have a good, clear washout. And in some cases, if you don't do the prep, sometimes you may be asked to do that gallon, and come back in a few days to repeat the colonoscopy. Trust me, no one wants that. In terms of surgery, an empty colon has been found to be a lot easier to work with and manipulate during the time of surgery. But also by doing the prep, we're able to reduce the risk of infection and complications after surgery. So that's why at one point there was a significant group of surgeons who just got rid of the prep and said, oh, you don't need to do a prep. But unfortunately that was encountered with a spike in complications and infection. So now the standard again is back to doing bowel prep before surgery as well.
Okay, thank you, Dr. Lamon, and thank you, Dr. Nieto. We have another question from someone who has a question related to family. It says, my grandmother passed with colon cancer. She was diagnosed 3 times. The first and second time it was removed, and the third time there was nothing else they could do. Does this put me and my siblings at higher risk, or our children? And anyone can take that.
Can you repeat that first part of the question? And how old is the patient too?
A grandmother passed away, and this is a granddaughter who's asking the question. Grandmother passed away, was diagnosed 3 different times with colon cancer. First 2 times it was surgically removed, the tumor was, and the third time it was probably at a stage where there was nothing they could do. And she wants to know, does this put them at risk, she and her siblings, at higher risk, or their children?
I guess I'll take that if that's all right. So this grandmother is a second-degree relative of the patient. We generally are usually concerned about first-degree relatives. Now, however, if the grandmother, it sounds like, had 3 different diagnoses across a certain time span, and I don't know that time span, but let's assume that the first cancer was diagnosed before the age of 60 or earlier. At that point, one can be convinced that there may be a family history, although generally we only consider about the first-degree relatives. But then it really falls down onto that, to the questionnaires parents, if they have any early onset colorectal cancer before the age of 60. If they do, whatever age they were diagnosed at, let's assume they were diagnosed at 50, then they need to get colonoscopies at 10 years earlier. So whatever age you were diagnosed at 10 years earlier, and then rather than every 7 to 10, every 5 years. And that goes for any first-degree relatives. If there's additional concern, we do have a cancer genetics clinic at Baptist MD Anderson that your primary care physician can refer patients to, and they can investigate. You know, it's kind of tricky over this kind of scenario, but they can investigate whether or not there is a predisposition. But generally we're worried about first-degree relatives and under the age of 60 or less.
Okay. Thank you, Dr. Lamon.
And I just wanted to add to that question. That's a very important question. And Dr. Lamon basically gave us the guidelines, and I completely agree with that. But there's sometimes specific scenarios, like I've had patients that they were raised by their grandparents and their parents had passed away at an early age from something unrelated to colon cancer. So we have to treat those patients like their parents also had family history. And it also depends, obviously, if the grandmother had it when she was 80 or when she had it when she was 50, when she was diagnosed with colon cancer. So sometimes you don't have the history of the parents. Sometimes we do have the history of the parents. To say that, the parents actually went and had their colonoscopies done because their mother had colon cancer at 55. So they started at 45. And at 45, guess what happened? They actually underwent their colonoscopy and found polyps at that time. So I would take that into consideration as well. The parents also having, which are now the first-degree relatives, having colon polyps because they were actually following guidelines. That's what the purpose of these guidelines are, is to prevent them from ever having colon cancer, including their children. So it's the guidelines are clear, but sometimes we're faced with these specific questions that the guidelines actually don't address specifically. Like, you had a second degree relative that's positive, and the first degree relatives are not positive for colon cancer because they've actually undergone screening and surveillance appropriately and prevented colon cancer. So that's a great question. And the key is what Dr. Lamon said. What's the history with the parents? And once we know that, we can make the proper recommendation.
Thank you, Dr. Nieto. So I have another question that's come from the audience that's along the lines of that question related to genes. Does testing positive for the BRCA gene have any relation to colon cancer? I think the risk increases with breast, ovarian, pancreatic, and prostate, but is there any connection with colorectal cancer? Anyone can take that.
I'm not aware that it's associated with colon cancer. I don't know if Dr. Nieto or Dr. Lamon.
Yeah, I'm not aware of any association with the BRCA genes. They are associated with the cancers that Ms. Sherman spoke about, pancreatic as well as breast cancer, et cetera, prostate.
Yeah, I agree. But there are associations with other type of genetic abnormalities, which I think are some of the questions that were asked in the Q&A. I think most of the discussion today has been on average risk patients. But some of the Q&A, appropriately so, asks about if patients have a family history or if they have a genetic predisposition, such as someone with hereditary non-polyposis colorectal cancer, HNPCC, or Lynch syndrome, or familial adenomatous polyposis, or other syndromes. And those cases, we really recommend those patients to see the gastroenterologist much sooner and get testing both at much earlier age than 45 and also more frequently. If you do have a genetic predisposition, you are at a significantly increased risk of developing colorectal cancer and some additional type of cancer, depending on which genetic mutation you have. And I think that's a little outside of the purview of this kind of discussion, but it is a significant risk. And in some cases we do, and we have performed successfully, prophylactic operations on patients because the risk is so high that we actually do prophylactic operations and remove patients' colons before they will otherwise inevitably get a colon or rectal cancer. But again, that's a very specialized talk, kind of outside over here. And it's probably best addressed, one-on-one with patients, physicians.
Okay. Okay. Thank you very much. So this question comes from Joy Burgess, and she says, there's so much misinformation, fear, and stigma in the Black community about cancer and the notion that what will be, and God determines what happens to you. How can we promote prevention in the Black community and early screening to save lives? Dr. Harris?
Yes, I'd like to speak. I was actually trying to type an answer to that. And Ms. Joy, I really think a lot of patients who hold that perception regarding getting screening are basing their choice on misconceptions and basically fear. And so as their primary care physician, I'm really trying to hone in on the fears that they have regarding getting the screening and dispelling those thoughts. I mean, you can't do it with everyone, but it may just be misinformation. They don't know what it entails. And so they're using that statement as a safeguard, because to say, God determines what happens to us and what will be. I mean, we go to work every day. We go to work every day to pay our rent and to pay for the car. We don't expect God to just perform it for us, there's something we have to do on our end of it. And so we know it costs money to buy a car. So what do? We work, we save, and then so that we can get it. And it's the same thing with preventative care. As physicians, we know certain diseases are preventable if we get the screening. And so it's our job, me being a patient or the patient that I'm serving, it's their job to follow those recommendations. And if I can dispel those fears to where they feel more comfortable, then great. But sometimes it doesn't work. And so every year, I remind them that when I see you in 6 months to a year, I'm going to talk to you about it again. And, just kind of talking to them and helping to alleviate those fears is helpful sometimes. But I'll admit it doesn't work all the time.
I mean, I can tell you from the easiest answer to that question is it's actually what we're doing today. These types of events, education, reaching out to the community, and letting them know we're here to help. Letting them know Baptist MD Anderson is here to help if they're in that situation where they need help, either with their screening or their treatment. So the answer is education, educating different communities in the community. What about their, what questions they have, what fears, why don't they want to have colonoscopy? Actually, I was in this situation with my parents. My parents said, we're not having colonoscopies. No one in our family had colonoscopy. We don't need to do that. No one, my grandfather in Cuba lived and he was like 90. I mean, that's all I got. and it wasn't until even after education and they had access, because I would, at that time I was a gastroenterology fellow, and I mean, I was still in training, and I could have helped them get screened right away, no problems. They still wouldn't do it. It wasn't until I actually used, the best tactics. I basically told my dad and my mom, listen, I'm going to be a gastroenterologist next year. If you don't get your colonoscopy and you have colon cancer in the future, how bad it's going to make me look? And then as soon as I said that, they're like, okay, get us the colonoscopy, we'll do it. And they had a great experience. Their fears were conquered, and now they've gotten them routinely and done great. So but again, it's education and letting them know that, we're here, we're talking to them, we're giving them access to care, and we have our experience. Like myself undergoing that colonoscopy really changed the way I see what people are going through. Just taking that prep, having the anxiety in the morning, even though I've done, like I said, over 10,000 colonoscopies, I'm on the other side. So I can really empathize with what fears they have. But again, it's educating them and letting them know your own experiences as well. Thank you.
Thank you, Dr. Nieto. So we're coming to a close for our session. I can't believe how fast the time has flown by. The audience has really been engaged and have had a lot of questions for the expert panel that we have here this evening, and it has really been quite interesting. So as we close, I would like for each one of you to take just a minute to share your statement. What would be your final statement to this audience about colorectal cancer? What advice would you give them? What would be your final statement? And each one of you, will start with Dr. Harris, and then Dr. Nieto, and then Dr. Landman.
Me first?
Yes.
Hi, this is Dr. Harris back again. I guess my main statement would be, colorectal cancer is a preventable disease. And that's why we're having this talk, because we want to prevent you, if you are at risk, from developing it. And I'd hope that each of you, if you've not had your colon cancer screening, would schedule. And even those of you who may not be at risk or not need to be screened at this time, if you would pass this information on to your family members, because you're the one that they trust and will talk to, so that they can get screened, and hopefully this information can save their life.
Thank you, Dr. Nieto.
Thank you. And again, all the participants, thank you for giving me the opportunity to talk to all of you. And thank you for inviting me to be part of this. And thank you to all the panelists and Ms. Sherman for putting this together. And the key thing I have to say, this is colonoscopy is not only a screening test, but it's a preventable test. We don't have we have tons of different types of screening tests for different types of cancer. This is the only one that not only are you getting screened, but you're also preventing yourself from ever having cancer of the colon by doing it appropriately. So, you know, we all have families, we all have people who love us. Think about them when making these decisions. You have to take care of yourself because you have a lot of people who love you. You have a lot of people that you mean a lot to, and especially, but also do it for yourself. It's extremely important. Thank you.
Thank you. Dr. Landman.
Thanks again, Ms. Sherman, for setting this all up for us. You know, we're all really happy to be here. And again, to kind of answer someone else's question, the whole point of this indeed was for education and outreach and to normalize getting screening colonoscopies. You know, everybody's got a colon and rectum. Everybody's got 2 arms, 2 eyes, 2 legs, and everybody's got a colon and rectum, and everybody really needs to get screened. So, but going back to that, you know, colorectal cancer can be a preventable disease. And the key to doing that is to get screened according to guidelines, because colonoscopy, like Dr. Nieto said, can be both diagnostic and therapeutic. And it's the only screening modality, including mammograms, chest CT, mammograms for breast cancer, MRIs for breast cancer, chest CTs for lung cancer, etc. It's the only screening modality that we have in the world of cancer that actually saves lives. But if you do get diagnosed with colorectal cancer, you know, seek out specialized care. You have that luxury, you have that ability as patients at Baptist Health to come to Baptist MD Anderson, where you will get tailored, personalized, and individualized multidisciplinary care, which will get you the best outcomes, again, not just for you, but also for your family and loved ones. We all all of us on this panel really wish that we never had to have this panel. But if we're here, we want to get all of you and your families and your community the outcomes you all need and deserve. And that's why we're here, and we want to be a resource for all of you. Thank you.
Thank you, Dr. Landman. And thank you, Dr. Nieto and Dr. Harris. With what you said, because we know colorectal cancer, when it's found at an early age, at an early stage, it does not have to spread. There's a 90% survival rate, 90%, just by having a colonoscopy on time, 90% survival rate. You never have to experience Dr. Landman having to do colon cancer surgery on you, or any other surgeon doing colon cancer surgery on you, 90%. Because we know how important this is, Baptist Health and Baptist MD Anderson Cancer Center are participating with Borland Groover to promote colon cancer screening throughout our community with a comprehensive campaign in March. That's why we're here tonight. We want all of you who are due for a colonoscopy to have a colonoscopy or to get screened, whether it's colonoscopy or Cologuard. Our goal is to, in this campaign, is to screen at least 1,000 people. We need 1,000 people who are due for a colonoscopy to have a colonoscopy. Of course, if you're not due for a colonoscopy, we don't mean you, but we also want you to get your colonoscopy when it's your turn. So tell somebody, tell your relative. I have told all of my sisters and brothers that they need to have a colonoscopy, and because what has happened in our life to our youngest brother, we are all over it. And I want you to be all over it as well. The incidence in the African-American community is no joke. African-Americans are 20% more likely to get colorectal cancer and about 40% more likely to die from it. That is huge. That is huge. And all it takes is you getting screened and having a colonoscopy to prevent dying from colorectal cancer. Get screened. If you want to get screened, just call 202 for you, and we are happy to schedule you to get colorectal cancer screening. So please call 202 for you so you can get screened, and tell all of your friends and family the same thing. It's important that we all get screened, especially if we are due for a screening. And now, remember the doctor said 45 years old, the insurance companies are covering screenings for 45-year-old. Colorectal cancer is a challenge, is a problem for everyone, no matter who you are, no matter what your race or ethnicity is. But it is significant. It is a significant disparity in the African American community. And it sounds like from what we've heard tonight, it's simply because our community needs to be educated. So I want to be a champion for this, and so does everyone on the Colorectal Cancer Task Force at Baptist Health wants to help all of you get screened. So call 202 for you to get scheduled for a screening. I'd like to thank Dr. Harris, Dr. Nieto, and Dr. Landman for being here with us tonight, taking their time to be here with us tonight to share their expertise on this subject. I'd also like to thank everyone behind the scenes who worked so diligently to put this all together, including the social responsibility team. Everyone, you don't see them, but they are working very hard to make sure that you get the information that you need. Again, thank you and good night.